and the Gates Foundation, and I'm now a consultant on global women's health. 2 weeks ago, the first session outlined the evidence behind the need to address diabetes and hypoglycemia in pregnancy, including the high prevalence of the condition, the fact that the SDGs framework calls for addressing maternal health and NCDs as a more aligned agenda. We were provided with information from WHO about the evidence and the impact, as well as the FIGO guidelines, and we were reminded that for women in low resource settings, pregnancy is a unique opportunity and often the sole opportunity to connect with the healthcare system. Today's session will focus on practices in various settings and the lessons learned from these on-the-ground experiences. We're going to learn from 4 eminent experts who share a passion for the issue. We will hear the 4 presentations back to back, 10 minutes each, and then we will open the floor for questions and comments, and you can send your questions throughout the session, and we will do our best to address them. The webinar is, of course, recorded, and you will be able to access the session as well as the first webinar. We have changed slightly the order of the presenters today, so we will start with Dr. Butta, whom I'm sure a lot of you know already, but let me introduce him briefly. Dr. Butta is the Robert Harding Chair in Global Child Health at the Hospital for Sick Children in Toronto, Canada. He is the co-director of the Sick Kids Center for Global Child Health and the founding director of the Center of Excellence in Women in Child Health at the Aga Khan University in Karachi. Dr. Butta also holds adjunct professorships at several leading universities, including Johns Hopkins, Tufts University, Boston University, and the University of Alberta, as well as the London School of Hygiene and Tropical Medicine. Dr. Butta was a member of the Independent Expert Review Group appointed by the UN Secretary General for monitoring global progress in maternal and child health. He served on the Gavi board. He is the co-chair of the Global Countdown for 2015 and 2030. He is also a member of the High-Level Health and Human Rights Committee at the UN and an executive committee member of the Partnership for Maternal, Newborn and Child Health. Professor Butta was educated at the University of Peshawar in Pakistan and obtained his PhD from the Karolinska Institute in Sweden. He is a fellow of several high-level academies, and he is also the current president of the International Pediatric Association, and his presidency runs from 2016 to 2019. He published 8 books and over 700 publications, including in The Lancet. He received several awards, and in particular, in November 2016, the World Academy of Sciences awarded him the prize in medical sciences for his contributions to newborn and child health in Pakistan and globally. Dr. Butta, you have the floor.
Well, good morning, good afternoon, and evening, and thank you so much for that over-generous introduction, France. My apologies also, colleague, that I'll have to leave in about half an hour, so I would request that if there are any queries and questions, that maybe I could be given an opportunity to answer them before I leave. I've been asked to quickly share with you thoughts on what are the global issues, challenges around pregnancy-associated prediabetes and diabetes, and importantly, what are the emerging opportunities for interventions? How can we do better than what we are doing presently? Next slide. If you look at this from the lens of particularly low and middle income countries, and I'll give you some examples from Pakistan in particular, even though this has not been a focus of attention so far, things are changing rapidly. You see in front of you on a slide which shows nutrition trends for women between 20 to 29 years of age that we collated for the Lancet Nutrition Series. And it's quite evident if you look at various regions that both the increase in proportion of women with the BMI of 25 or more, and in particular those with a BMI of greater than 30, in some regions that increase is quite significant. Look at what's happening in the Oceania region and also in parts of Africa. If you look, next slide please, if you look at this in the context of various age groups, we published these data in the Lancet a few years ago, looking at the global prevalence of obesity and overweight, and it's interesting to see inflection points which particularly relate to the age groups of adolescents and beyond, and it seems that both obesity and overweight seem to be related to changes in lifestyle around that period of time. So although there's a lot of interest in the antecedents of both of these as risk factors for diabetes and other chronic diseases, lifestyle factors seem to be quite important. Next slide, please. What is the situation in Pakistan? I thought I would share with you some recent data from an analysis that we have done on looking at trends of both undernutrition and overweight and obesity amongst adolescent girls in Pakistan. And if you look at the right side, which summarizes data from a national nutrition survey, you will note that while yes, short stature and being underweight are widely prevalent, but also notable are overweight and an emergence of obesity in the same age group. So we tend to see a double burden contrasting between rural and urban settings, and also importantly related to lifestyle changes amongst those who migrate from rural to urban. Maybe the best way I can show this to you is through some geospatial maps of the distribution of both of these contrasting conditions in Pakistan. So if you look at this map of maternal undernutrition reflected as wasting, low BMI by various districts, you see very clearly that this is largely a condition notable in the south and southwest of the country. Poorer provinces of Sindh and Balochistan. Look at Punjab. In the north of Punjab does not have the same issue of maternal wasting. But what does the north of Punjab have now? Next slide. If you see the same distribution of maternal obesity from our Bayesian analysis of malnutrition in Pakistan, you will see that this is emerging as an issue in some provinces where there has been a nutrition transition. And you've got close to a fifth to a quarter of all women of reproductive age with notable obesity. So these are extremely important demographic changes. And it's therefore not a big surprise that when you look at the global context in the next slide, you will find that in a recent analysis globally of what has happened to age standardized prevalence rates of diabetes in adult women, in some of the same geographies of the world that we know, these prevalence rates are as high as about 5 to 10 to 15%. In the Middle East in particular, this has been a very rampant, rapid change. And this is happening as we move the non-communicable transition from undernutrition scenarios to perhaps now the converse. Why does this matter? So if you, in the next few minutes of my presentation, I would like to focus a little bit on why this is critically important, both in the context of short-term and long-term outcomes. So next slide. Graphically, in looking at the relationship between linkages of maternal and newborn health, a range of conditions, not just nutrition, but also conditions that relate to infectious diseases and other chronic disorders, profoundly influence not only short-term outcomes in the mother, which may relate to even life-threatening conditions, but also perinatal, newborn, and young infant outcomes. So these things are fairly well recognized, both in terms of risks and also in amelioration strategies. I'll give you one example in the next slide, which France may recognize as work that we did some years ago on looking at the interconnections between maternal status and newborn perinatal outcomes. So here summarized is some data from studies looking at both perinatal mortality as well as impaired glucose tolerance in the same cohort, in the same subjects. And you'll find that clearly both are interrelated, and there are outcomes which are affected for both maternal and newborn indicators. The next slide, what can we do? What can be done? Ideally, next slide please, you ought to be starting before pregnancy. But this one slide of mine, which summarizes, the relationship of preconception care, although it does show very clearly that if you have interventions for prevention of gestational diabetes mellitus, and are able to introduce those prior to pregnancy, you can certainly reduce the risks of development by about 70%. But note that most of these studies, in fact, the vast majority of these studies except one, are from high-income settings. So the numbers are low, so therefore overall quality of the evidence is relatively poor, but it does suggest that something can be done preconceptually. Next slide. I tried to summarize some of the most recent evidence on interventions that can make a difference for the prevention and treatment of diabetes. And as you will see from this summary slide, we have 4 very recent Cochrane reviews of the evidence, which is quite important to underscore that these are quite current data. And I'll quickly go through some of them in terms of what do we know works and how can we make it work. So next slide. If you look at the interventions that we have for the prevention of gestational diabetes mellitus, it looks like dietary advice and interventions for prevention can reduce both risks of development of GDM, but also additional morbidities that have been long recognized to accompany obesity and diabetes mellitus, such as pregnancy-induced hypertension. Next slide. You can see that clearly in the forest plot that you have here from the study summarized that there is close to around a 40% reduction, which barely reaches significance in terms of the risk of development of gestational diabetes. Next slide. And also a significant reduction in these studies summarized in the risk of pregnancy-induced hypertension. If you look at interventions that we have for the management of gestational diabetes mellitus, next slide, the evidence is more mixed. And here, the number of studies and overall quality of the evidence suggests that it is insufficient at the moment for us to be recommending this in programmatic settings. So both different types of dietary advice for women with existing GDM and also oral pharmacotherapy do not seem to have yet have sufficient evidence behind it for us to end them. Next slide, please. On the other hand, the evidence around lifestyle interventions for the management of gestational diabetes, which include both education as well as improvement in terms of physical activity and diet management, seem to have quite a significant impact in the reduction of the risks of birth outcomes like macrosomia, large for gestational age births, reduced prematurity rates, and also maternal outcomes like postnatal depression. Now, I must underscore one thing, that this may seem like a very limited repertoire of outcomes, but these are the ones that have been measured in the literature. We still have a long way to go to improve our listing of interventions that we can put in and outcomes that we can measure in some of these studies. So I'll show you some of the forest plots to give you a sense of the distribution of the effects of the data. So this is macrosomia, about a 40% reduction in that risk, highly significant. Next, you can also see that in the context of large for gestational age births, obviously interrelated, same, which I think is a robust impact in the same direction. Next, you can also see this in prematurity rate reduction, which we find very interesting because there are not a lot of prematurity related interventions out there. The association of prematurity with obesity and impaired glucose tolerance has been reasonably well established in the observational literature. But these data from these 3 studies, including one which is relatively recent, suggest that we can do something about it more substantively. So quickly on the next 2 forest plots, you will see impacts on gestational weight gain. Next, on also postnatal depression, which, although it's limited to just one study by Caroline Crowther, but tells us quite clearly that one can look at maternal morbidity and outcomes in this. What about adolescents? So we have recently looked at the evidence base for adolescent nutrition interventions, just published this month in the Annals of New York Academy of Sciences, and it looks as if even though the number of studies are limited, the evidence is broadly in the same direction that you see for older women of reproductive age, which is quite salutary and interesting for us. So next slide shows you the summary of the effect of of management interventions for the management of obesity, and as you can see, there is not a lot out there overall to recommend, but family-based interventions are effective. School-based interventions are effective from the limited number of studies, but overall, the data does not show a hugely greater impact in this age group compared to what we have seen in women of reproductive age. So my dominant take-home message from the existing literature review on management of obesity is that although effects are broadly in the same direction, we still have a long way to go to implement interventions effectively with reasonable sample sizes in this population. What can we do to package and bring these interventions together? Next slide. Let's jump this slide. I want to talk a little bit about packaging interventions together. Now, classically, for our maternal and newborn interventions, we have tended to club them around family and community interventions. And from the literature that we have available, it looks like a range of these interventions are possible in family and community settings, particularly lifestyle changes and changes that can be administered at large community platforms. Next slide. You can add to this through outreach programs. Next slide, please, such as those one can implement through community health workers. If you go back one slide, and things that can also be put in referral centers, particularly at the lower end of the health system. Now, the evidence around many of these interventions for integrating gestational diabetes, diabetes care, and obesity prevention may be at this point in time still under development, but it's broadly in the right direction. And what we principally need now is much more implementation and evaluation in low and middle income settings. So I'd like to stop at this slide and just encourage that we proceed more in this space. The evidence base for this is growing, and I'll be happy to take any questions or clarifications. Thank you very much.
Thank you so much, Dr. Bhutta, Zulfi, for this very clear demonstration on the interconnections between overnutrition, obesity, and diabetes, the importance of prevention, and the impact of lifestyle interventions for impacting on mothers' and children's outcome. And it was interesting to raise the issue of adolescent nutrition as connected with diabetes in pregnancy. They are the future, isn't it? So we will thank you, Dr. Bhutta, and we will now hear from Dr. Anil Kapoor, who is with the World Diabetes Foundation. He is the chairman of the board of the World Diabetes Foundation. He will introduce the foundation's work on support to underground programs. Dr. Kapoor has a very impressive resume as well. He served as managing director of the World Diabetes Foundation from 2006 until 2013. He has over 35 years of experience in clinical medicine, clinical research, business, diabetes advocacy, and public health. He received his medical degree, internal medicine, in 1981 at the University of Baroda in India. Dr. Kapoor worked as managing director of Novo Nordisk India, later as vice president of Novo Nordisk Regional Office for India and vice president of Novo Nordisk Corporate Stakeholder Relations for Asia. He also has served as a managing trustee of the Novo Nordisk Education Foundation in India. He has published more than 90 papers in peer-reviewed journals and has written over 10 monographs on diabetes for medical professionals, but also books for lay people. Dr. Kapoor is the vice president of Asia Initiative Pregnancy and a member of the FIGO working group on hyperglycemia in pregnancy. He is the recipient of Denmark's Prince Henrik Medal of Honor. Please, Dr. Kapoor.
Thank you, Franz, for that nice introduction. As Dr. Bhutta clearly mentioned at the end of his presentation, that there are initiatives that need to get into public space and be implemented. So I'll carry on from there and introduce the work of the World Diabetes Foundation. So most of the people hearing this webinar would be aware of the fact that the burden of diabetes is growing quite rapidly and continues to rise quite precipitously. It is in this context that the World Diabetes Foundation was established in 2002 to try and see if we could help the low and middle income countries with starting interventions to address the prevention and care of diabetes at the primary care level. So basically, the World Diabetes Foundation was set up in 2002, and the role of the foundation was to fund projects to address the burden of diabetes, to act as a catalyst to create enabling partnerships, link people and resources to advocate globally and provide care locally, and support existing systems to strive for sustainable solutions. And in our remit, it was very clear that we will only target the poorest of the poor, and we will only fund programs in the developing countries. So most of our initiatives are not in Europe and North America, but in the developing countries around the world. So basically what the WDF works on is through three pillars. We do a lot of activities around advocacy, around primary prevention, and in terms of improving access to care for diabetes. Under the advocacy pillar, basically our task is to support global stakeholders such as Women Deliver and others, and empower local stakeholders, facilitate global network of partners. In the area of primary prevention, we have basically decided to restrict ourselves with three areas. The school health promotion, because that is very critical. We are also aware of the fact that primordial prevention of diabetes and many of the cardiovascular diseases might actually originate in fetal programming, and therefore paying attention to maternal health during pregnancy, both on the nutrition as well as through the gestational diabetes initiatives. And then also work on community awareness and screening in high-risk groups and opportunistic screening. In terms of access to care, our basic premise is building capacity for diagnosis and treatment of diabetes and its comorbidities. And we have decided to focus ourselves on a few areas, primarily on addressing the primary care for diabetes at the primary care level, addressing the area of diabetes in children, diabetes in mothers through the gestational diabetes initiatives, looking at prevention of amputations and ulcers in people with diabetes through the diabetic foot care initiatives that we have been rolling out for many years now. And then prevention of unnecessary blindness and preventable blindness because of diabetes by focusing attention that people with diabetes need to have their eyes examined and particularly be provided appropriate care for it. The last but not the least of the initiative has been to bring attention, global attention, to the issue of the links between diabetes and tuberculosis and how diabetes could actually undo the developments and the progress that has been happening in terms of control of tuberculosis globally. I wouldn't spend time on discussing that. But basically, if we look at our partnerships have been at the global level. We have tried to work with many UN organizations, in particularly with the WHO Global Coordination Mechanism, with also the WHO diabetes programs. One of the first of our action points was the Diabetes Action Now of the WHO, which we supported. We have been also working with the World Bank in different parts of the world, and with the United Nations Development Program, ITU, and with the professional organizations such as the IDF, the International Union Against Tuberculosis Lung Disease, the Federation of Obstetrics and Gynecology, and the NCD Alliance, etc. And then also with large international NGOs such as Women Deliver, Fred Hollows, looking at the diabetic retinopathy initiatives, the Alliance International, Site Savers, PSI, etc. At the regional level, of course, we have been working in close collaboration with many of the WHO regional offices, in particular with PAHO and Southeast Asia Regional Office, and also the Western Pacific Regional Office, where we have funded initiatives addressing diabetes in different countries in these parts of the world. We have been working very closely with UNURWA in terms of providing access, where UNURWA has been working in providing access to diabetes and hypertension care for the Palestinian refugees. And then, of course, we have been working with local stakeholders, ministries of health, local champions, etc. So if we look at our focus area in terms of access to care, basically it has been to strengthen primary healthcare level, and I would not spend time talking about many of these initiatives that we have rolled out in terms of establishing clinics, providing equipments, building capacity, in terms of providing funding for training of staff, developing guidelines, educating patients, developing peer groups and supporting families, establishment of mobile units with outreach initiatives, and mobilization of community health workers, etc., etc. In terms of hypoglycemia and pregnancy, the World Diabetes Foundation, since its inception, has supported almost about 74 projects, and these projects have helped strengthen about 4,500 clinics with their ability to screen for hypoglycemia and pregnancy. About 850,000 pregnant women have been screened through our programs for hypoglycemia and pregnancy, and approximately 110,000 healthcare professionals have been provided appropriate training depending on the task that they do in terms of addressing this issue. And the work of our foundation through various activities has led to policies getting in place for universal screening, and these have been done in India, in China, Sri Lanka, and Colombia. In terms of the funding, the foundation has funded about $11 million US, but for every dollar that the foundation funds, we are able to leverage about $2 from local partners and the health systems that we operate in, and therefore sufficient funding has gone into these initiatives. Primarily, most of the funding has gone in three different regions, particularly Southeast Asia, which includes the SAARC nations, and Western Pacific region, primarily China, and in Africa. Next. In terms of awareness creation, these are some of the pictures where our programs have launched massive awareness creations in women's self-help groups, in local NGOs, about the issue of hypoglycemia and pregnancy, and why pregnancy is such an important aspect of a woman's life in terms of determining the health of the baby and her future health, and using pregnancy as a hook to be able to get to women and their families in relation to not only gestational diabetes, but diabetes in general. Next. As you could see, in the previous slide, you could see one of the pictures where you can see a large number of girls in a local college and school who are also being sensitized to the issues around obesity and why it is important to be aware of not putting on excess weight, etc. In terms of screening and care, as I mentioned, 4,500 odd clinics have been strengthened. You can see some of these pictures from our projects in China, in Colombia, and in India and the Middle East. Next slide. And our projects have obviously developed a lot of patient education materials which are available as inspiration for other project partners as well as to other people who may want to do activities around this. So you can see some of these samples from China and from Nicaragua and Colombia. Next. In terms of advocacy, we have been engaging and supporting stakeholders, and we started actually working in this area from a long time ago. One of the first initiatives was a meeting that we organized on women, diabetes, and development at the UN headquarters in collaboration with the Women's Alliance for Health. And subsequently, we've been rolling out many initiatives. We have particularly worked very closely with FIGO, which has led to the development of the FIGO guidelines and several publications in the International Journal of Obstetrics and Gynecology. We have worked very closely with the Pan American Health Organization, organizing a large meeting in Lima, where ministries of health of 32 countries got together to look at how this issue of hyperglycemia in pregnancy can be addressed in a more structured way. We've worked with women's rights groups, in particular with ARROW, an organization which has been working in the area of sexual reproductive health and rights. And this is something that often gets missed out, that diabetes is a very important part of the sexual and reproductive health and rights of women, and unfortunately little attention is paid to it. We have worked very closely with Women Deliver, and as you can see, the next speaker, Dr. Chandrika, is speaking at the Women Deliver meeting in Copenhagen last year. And one of the pictures you can see is the Indian Health Minister, who was part of a large initiative where we did a high-level meeting to discuss the linkages between the MDGs and the maternal health and non-communicable diseases with special reference to women and diabetes. And as a consequence of these initiatives, we were able to ensure that the government of India understood the importance of this issue and actually developed the guidelines, which I'll show you in a little while. We have also tried to share the learnings from the World Diabetes Foundation funded projects. For example, this initiative that we did with one of the largest media houses in India, the Dainik Jagran Group, which launched a massive awareness campaign in 14 states in India. And the learnings that came out of that initiative were published and reviewed by KPMG and then published. Then the work that has been ongoing in Nicaragua, and I'm sure Heather would be talking a little bit about it, and also the large initiatives in China, which got published in Lancet Diabetes Endocrinology as a commentary on gestational diabetes in China, and also other publications. Next, please. One of the things that has come out very clearly from the project that we ran in Colombia, where we identified 5 principles that one needs to consider when establishing a GDM project. And one of the first ones was that we need to do a universal screening for all pregnant women. A risk-based screening does not work. That the second point was that we need to integrate GDM screening and care into maternal and child health services, making GDM screening and management an integral part of the MCH initiatives. We also need to engage community health workers, which becomes a very important part in terms of rolling it out on a large scale. And then we need to empower pregnant women, particularly with the knowledge on how they can handle pregnancy and hyperglycemia in pregnancy through lifestyle issues, and also to mobilize diverse stakeholders around a shared value proposition led by a strong local team. And these learnings are quite crucial in terms of rolling out these initiatives further on. And lastly, in terms of policy impact, the work of the foundation, as I mentioned, led to the development of the national guidelines for diagnosis and management of gestational diabetes in India. an initiative that was also supported by the Ministry of Health and Family Welfare, the Rural Health Mission of India, and also by UNICEF in India. Similarly, the GDM guidelines were issued by the Ministry of Health in China, and now these are part of the national initiatives, and all women are being screened for it. Also, in terms of advocacy, working with FIGO and with the South Asia Initiative for Diabetes in Pregnancy, we were able to launch the Colombo Declaration on Hyperglycemia and Pregnancy last year in Colombo, and the picture you can see the Health Minister of Sri Lanka with the President of FIGO and several other people signing this declaration. Subsequent to the SIDIP declaration, we've also been able to launch a declaration in collaboration with FIGO at the Barcelona meeting, where the European Association of Perinatal Medicine and the European College and Board of Obstetrics and Gynecology with FIGO actually created the declaration, Barcelona Declaration for Hyperglycemia and Pregnancy in Europe. We intend to work with FIGO in different parts of the world and actually create advocacy and awareness and actually get the healthcare providers on a common platform to start addressing this issue. So thank you very much for your patient hearing. If you have any questions, I'd be very happy to answer later on.
Thank you so much, Dr. Anil, for highlighting the work of the World Diabetes Foundation in the areas of advocacy, prevention, access to care, highlighting partnerships and demonstrating the importance of universal screening, the training of providers, the school-based awareness programs with impressive success in India, for instance. So next, you mentioned Dr. Chandrika, who is working in Sri Lanka and making impressive strides in Sri Lanka. Dr. Chandrika Wijeyaratne, he's a professor of reproductive medicine and endocrinology at the University of Colombo, Sri Lanka. She will talk about the program and in Sri Lanka, the challenges and lessons learned, and we will hear from her in a second. I just want to mention that in 1993, Dr. Chandrika became the first endocrinologist appointed to an academic position in Sri Lanka. She went on to establish reproductive health medicine and maternal health as centers of excellence within the country. She led several critical studies showing the high prevalence of metabolic dysfunction and gestational diabetes among South Asian women. Dr. Chandrika served as president of the Sri Lankan Endocrine Society and is president-elect of the Sri Lanka Medical Association. In 2008, she organized the largest ever event undertaken by the association, designed to address the identification, control, and prevention on diabetes and cardiovascular diseases throughout the country. And she is the recipient for the International Excellence in Endocrinology Award. Dr. Chandrika, over to you.
Thank you, Franz. Thank you very much, Franz, for those kind words of introduction. Greetings to you all from all parts of the world. I'm actually seated in beautiful valley of Kashmir in India at a meeting at the polycystic ovary syndrome and how it is linked to gestational diabetes. So my task today is to share with you some of the challenges, successes, and lessons we've learned through a program funded called Nirogi Mata, funded by World Diabetes Foundation, which has been in effect for 3 years, ending last year. And I thought I will share a story with you, which is a common phenomenon that we come across. This is a true case scenario set in the metropolitan city of Colombo. This lady in question, whom I shall refer to as Mrs. Sri Lanka, is a mother of 4, and she found she was pregnant when feeding her 10-month-old youngest child. She weighs a heavy 80 kilograms and has extremely high blood glucose, which was detected by her field midwife, since Sri Lanka has the unique capability of registering mothers for very early antenatal care. She is very withdrawn and not communicative, and the field midwife informs our services that she has many a social issue, particularly that her husband was recently remanded in prison for tapping electricity illegally, and the fact that they live in very overcrowded, impoverished conditions in a wooden home, just a mere 3 square meters in size. They basically live in the slums of our metropolitan city and use the public services for water and sanitation. Now, Mrs. Sri Lanka was found to have her high blood glucose, and she was commenced on insulin, as you can see in this slide, and she has been on it for the past 3 months with support from our clinic service. But I could recall her since she had very clearly had pure gestational diabetes, which is diabetes confined only to her pregnancy, in her 3rd pregnancy. And at that time, because she had close links with our clinic members, she in fact brought her mother, who was 45 years old, who herself was a diabetic for many years. She was partially blind and was very wasted and was actually on crutches with 1 leg amputated. This lady, the mother of Mrs. Sri Lanka, was unaware that her other foot, the one functioning foot, was infected. And in fact, we had to make arrangements to give her the services from the National Hospital, which is just next door to our hospital. Sadly, Mrs. Sri Lanka's mother died before the birth of her 3rd child. The next slide, please. Now, when she was 8 months pregnant, we realized that although we provided her free insulin, premix insulin twice daily, she had to purchase disposable syringes for its out-of-pocket expenditure. And in fact, she had no refrigeration facilities and she had to depend on a caring neighbor. We also had to make arrangements to admit her to hospital once every 2 weeks to make sure that she was getting the appropriate amount of insulin by testing her in her laboratory for a blood glucose series, since she could not afford a glucometer, which is not possible to be provided free of charge in our existing health system. But we as carers were faced with a huge dilemma. The fact that when she's in hospital and on a hospital diet, her blood glucose levels are very high, while at home she tends to get hypos, which is low blood sugar, while on the insulin. She never kind of explained to us as to why this was happening, and we realized that she had to rely upon a kind neighbor to keep her children, even to come in for these blood glucose measurements, which was quite inconvenient to her and her family. Next slide, please. Well, our diabetic educator nurse, who was actually trained by the Nirogi Lanka project funded by the World Diabetes Foundation, actually was able to get to the root cause of this dilemma that we faced. In her face-to-face discussions with the family, the diabetic educator nurse was able to find out that in each hospital visit, she gets hospital diet, while at home, she has very little food to go around and she's the last to eat, and often has to miss out on her meals. And she almost never had a choice of having an interval snack to prevent the hypos of the long-acting insulin. So basically, she had no social support, and all this information was really obtained from a 16-year-old son, whom when the nurse brought him into our clinic, we realized he had chronic undernutrition and actually looked like an 8-year-old boy. So at this point, we also realized that she was really short of money because she was on a daily paid job, probably earning about $3.50 3 times a week, which was insufficient to provide her with these interval snacks. And we prevailed upon the hospital Buddhist monk to help us out, and he acceded to our request very kindly. And we really solved her problems of getting these hypoglycemic episodes at home. And what was very touching was that Mrs. Sri Lanka, who belonged to a different community, used to always come and update me upon receiving the donations from the hospital monk. My question to you is, how has our system failed? It is clearly a socioeconomic determinant of the problem of diabetes in pregnancy, which is depicted in this case study. The next slide, please. If we were to predict as to what would be the future for Mrs. Sri Lanka, well, we can be fairly sure that she's going to be continuously sick with high blood pressure due to impending renal failure, neuropathy, and liability to even amputation of her legs, just like her mother, blindness, and even coronary artery disease and strokes. Women with diabetes are said to even have worse problems related to diabetes in outcomes than men worldwide, and the main cause is an unhealthy lifestyle due to lack of knowledge and poverty. Food rich in starch, sugar, and oils, and physical inactivity has led to obesity. I mean, even though Mrs. Sri Lanka was socioeconomically poor, you may remember that she weighed very high, 80 kilograms at the onset of her pregnancy. And this obesity actually occurs more around the waist, in particularly South Asian groups. These are all preventable. Sound universal knowledge, proper support and skills, development, healthy behavior, and a sustained non-health sector supports can bring about many changes and prevention of problems. In fact, education is very vital in this situation in other sectors that are non-health, and particularly environment, healthy inputs from all sectors, which will cover food, transport, and administration, above all, a healthy mother and a healthy family. The next slide, please. So basically, I would like to emphasize that women are not protected from the problems of diabetes, and that we need to appreciate that we have to give them special care. The next, please. The other issue about diabetes in women is that they have to face, they are liable to stigma and marginalization due to cultural issues, lack of support from family and even peers, and they feel very restricted on a day-to-day basis. They have problems with body image and body weight, and they have financial stresses, as depicted very clearly in this case study, and very few options for outdoor exercise in the overcrowded settings that they often have to live in. Next slide, please. And as the two previous speakers said, we need to take a life cycle approach with respect to women, particularly from fetal life to infancy, prepubertal, adolescent, and right up to the postmenopausal period, because many of our communities have a very long life expectancy in general. Next slide, please. As you can see, when a woman has very severe diabetes and liable to have vascular dysfunction, and diabetes and high blood pressure of pregnancy go hand in hand, they very often produce low birth weight babies. And then their genes can get affected, whether they are low or excessively overweight babies, and this is what we call fetal programming. And such babies have greater propensity to have catch-up growth and obesity from a very early age. And during adolescence, they start becoming anovular and have irregular periods and have even situations of developing polycystic ovary syndrome. So they run into problems of fertility, and these pregnancies that such people are more liable to gestational diabetes, pregnancy-induced hypertension, and again, intrauterine growth retardation. And such women, of course, if they do not lose weight substantially in the postpartum period, often have further weight gain with each pregnancy and are more liable to metabolic syndrome and coronary artery disease risks as they move on in life. And if they live well beyond the menopause, they have problems with taking hormone replacement therapy. So you can see very clearly that what is the seeds that are sown during your time in your mother's womb can well be translated into very unhealthy lifestyle, course events throughout the woman's life, as well as passing it on to the next generation, which can get affected even earlier than what the index mother did. Next slide, please. So what we wanted to do in Sri Lanka was that we had a very sound maternal and newborn health system. But through the World Diabetes Foundation, we developed a task force in diabetes prevention at the Sri Lanka Medical Association, and we found that we wanted to prioritize as a group as to improve the quality of care for diabetes, as well as strengthen primary prevention of diabetes, which had a very strong proper approach, as you heard from the chairman himself. And our main concern was to actually bring about these changes through existing health systems as well as with a voluntary contribution by the task force. Next slide, please. So when I prioritized, next slide, please. Yes. When I prioritized whether we could prioritize gestational diabetes in the first round, I was told we will have to wait a little longer because that was not priority. And we actually developed this cohort of diabetic educated nurses along with a novel healthcare model of boosting up the primary healthcare by partnering them with the tertiary care specialists located in the diabetic clinics, as well as to bring about a most important health promotion in prevention of diabetes and cardiovascular disease by empowering vulnerable communities, both in schools, workplaces, and in the communities themselves. But what we were able to do, as you can see in the next slide, is we developed modules in gestational diabetes and kept taking on the message forward even through the overall component 1 of the Nirogi project. So the 417 nurses were trained to serve in all parts of the country, had some idea about gestational diabetes and how to counsel a woman on lifestyle modification when she was detected to have diabetes in pregnancy. Next slide, please. And as you can see, that is the geographical distribution of these nurses. Next, please. And this is the maternal and child health system that has been functional over the past 50 years in our country, which goes down well down to the grassroots level, and where the midwife, a trained field health worker, can actually access the women in their homes, and that is how we have almost 95% coverage within the first trimester of all pregnancies to be registered and receive proper care. So ideal platform to access and get on with universal screening. Next slide, please. So that is how Nirogi Mata was born in the phase 2. And by which time we had developed most of the training modules for the nurses, which had to be modified for the field staff and the midwives. But as you can see, the next slide, please. This really aimed at addressing primordial prevention across generations, and the concept of a South Asian initiative was conceptualized again with the help of World Diabetes Foundation in Agra, India, where we championed for this by saying that investing in pregnancy diabetes is actually would have a very good payoff in having a healthier generation. Next, please. So the Nirogi Mata program really wanted to develop a national screening method as well as develop guidelines and develop the IEC material and training of trainers, with also collecting of some evidence for us to be able to take this further forward. Our chief partners were the Family Health Bureau, which runs the Maternal and Child Health Program of the Ministry of Health, and we are very grateful to them for taking it on to ensure sustainability, as well as the leading professional colleges, the obstetricians, physicians, endocrinologists, and GPs throughout the country who manage these patients. The next slide, please. So these are some of the outputs, booklets, and in fact the field midwives wanted us to develop a video on exercise, physical activity during pregnancy, which was otherwise not an accepted social norm during pregnancy for a woman who's pregnant to exercise. And the next slide, please. And just to share with you how we were able to target more than 6,000 healthcare workers by training of trainers who led the MCH program, who in turn trained the provincial and district level trainers, and who in turn really trained the field midwives and the nurses and actually supervised their data collections. Next slide, please. So the first IDIP conference, which Dr. Anil Kapoor showed you, was also coincided with a master training program for all the sectors that were relevant for gestational diabetes in one hall, to revisit all these problems and actually to discuss the challenges they face. So that was a very useful exercise, which I found to be something that we need to do regularly. And we also did not miss out on the fact that using glucometers and using the basic convenient DIPSI method for screening in the field of checking the blood glucose after a 75-gram glucose challenge test, we found an appalling almost a quarter of the women having the problem even in the first trimester. Next slide, please. Of course, since there are confounding reports from all over, there was a lot of confusion, particularly amongst the specialists, about anecdotal events and technical issues. But what we have encouraged is to focus on universal screening method so that every woman, through greater awareness, will check herself. And we have had many worthwhile research being done thereafter. Next slide, please. And thereafter, we did this basic study in the population-based study, which showed that pure gestational diabetes in the second trimester affected as much as 14% of women. Next, please. And next slide, please. And this also showed that when we followed up these women who were screened from 1,400 women, and the 168 women who were diagnosed to have gestational diabetes during this current pregnancy, that 10% of them remained diabetic in their first postnatal assessment at 2 months postpartum. So this was quite revealing and justifies that we have to do universal screening. Next slide, please. And when we also looked at our basic tertiary care clinic data, we followed up these mothers and babies and found that the majority of them were people who had gestational diabetes, but more than a quarter had previously unknown pre-gestational diabetes. Next slide, please. So therefore, the diabetes in pregnancy to gestational diabetes was almost 1 in 2. As you can see in the next slide, we declared 10th of March every year as GDM Awareness Week as a follow-up to the Colombo Declaration. Next slide, please. And where this notice in the vernacular says, your child is important to you, but both of you are important to the country. And this is a very strong message to all the women out there to ensure that they have a preconceptional check as well as to screen themselves during pregnancy. So have we achieved our objectives? Well, universal screening is achievable by joining an existing strong system which can achieve universal health coverage, and empowering the public, the community and the family for a life cycle approach is extremely important. Thank you very much. So let us unite in really promoting healthy behaviors in many settings, from the community to the clinics, and particularly to concentrate on family health. Thank you.
Thank you, Dr. Chandrika, and I hope the audience, you can bear with us for a few more minutes. We will hear a very good presentation from Dr. Heather White, who is a technical advisor for non-communicable diseases at PSI, Population Services International. Heather has a doctorate in public health, and as a technical advisor in PSI, she oversees and coordinates the implementation of current NCD operational plan to provide strategic and technical input on their NCD's programming. She supports country offices. Prior to this role, Heather was a member of PSI's new business development team and a program administrator and educator at the University of Alabama at Birmingham School of Public Health. She also served as a Peace Corps volunteer in Burkina Faso. Heather will talk about the programs in Nicaragua. Heather, you have the floor.
The opportunity to present from Women Deliver. I will keep it brief, but I will give some updates and insights on a project that we conducted in Nicaragua over the past several years. Next slide. So, as many of my colleagues on the phone have alluded to, one of the most interesting and compelling aspects of gestational diabetes is that the condition itself really does manifest across the life cycle. So when we think about this approach to prevention and management of the disease, we really are thinking about what is happening in terms of fetal programming, increased risk for cardiovascular diseases across the life cycle, both for women and for children. Next slide. And so back in 2013, we approached the World Diabetes Foundation and Novo Nordisk with an idea in mind to work within the private sector in our clinics there, primarily in Managua, to start to address diabetes in pregnancy and gestational diabetes. And at the time, diabetes in pregnancy was really not recognized as a public health concern. It was much more about medical management of the disease. And in that sense, it was very much managed by clinical specialists. And there was a real emphasis not as much on prevention, but really on disease management and relatively low public awareness of the disease itself. So when you look at the sort of the background context of demographic profiles in Nicaragua, you'll see, as was suggested by colleagues on this phone, a relatively high obesity rate, relatively high poverty rate, and also an unclear indication of what the gestational background prevalence of gestational diabetes was. Next slide. And so we worked with our local teams to put together a model of care that really did emphasize prevention as a primary component and lifestyle management. We started to work with clinicians in our centers. These clinicians, the centers themselves are embedded in larger tertiary care facilities, social security hospitals in Managua, where we were able to work with nutritionists who, up until that time, really were only managing the diets of inpatients in the facilities. So we approached these nutritionists to start to work to build out a team that could interface with women who were diagnosed as either diabetic or pre-diabetic to start to build out a lifestyle and dietary component to management of gestational diabetes and diabetes in pregnancy. Another focus of the program was to really look at what tools would women need and want to be able to empower them on a daily basis to make better lifestyle choices with respect to managing their pregnancies. And then fourth, a component to really think about what is the advocacy piece needed, both within the private sector, but also thinking about working across the health system. So, you know, what did policymakers need to know and understand about this disease and its implications with other chronic diseases, and what voice could we lend to that? Next slide. And so if you look at the program achievements over the 3 years, we were able to train just over 550 providers. Those were nurses, doctors, nutritionists, and lab technicians, working within 7 hospitals and 11 satellite centers. One of the components of the project was an educational piece wherein we would interact with women via text messages, sending motivational messages about education, reminders for appointments, etc., and so generated lots of those. We had a GDM detection rate of 12% among the women that were tested within the program, and almost 90% of the infants born under the program were normal birth weight. Next slide. This just shows our program results across the 3 years where we worked, and you can see we did quite a bit of screening, relatively modest diagnosis. It was a 2-stage screening process. Women were screened at their first presentation and followed up with an OGTT, and then we defined program success as women who were able to complete at least 2 nutritional counseling sessions. And we had fairly good numbers on that, but I think we learned a lot about what we might consider differently about interfacing with women around nutrition and counseling over the long term. Next slide. In terms of the insights, you know, we recognized early on that to be able to coordinate a high-quality team of care was going to take time and was going to take us to really looking critically at the systems and how we provide care for women. But I think we did find some really insightful kind of operational pieces that I'd be happy to share with anyone who would be interested in speaking about those, about ways that we could streamline care for gestational diabetes detection and management. Next slide. And we really did feel like we walked away with some great tools that are put together both in Spanish and in English. For those who may be interested, would be happy to share those about ways that women could stay on track and monitor their own progress as they moved through their pregnancy and postpartum around management in terms of exercise and diet. Next slide. Well, only to say that I will echo the sentiment on this call of my colleagues and others, which is to say that we all know diabetes in pregnancy plays a key role in the health and longevity both of mothers and of infants and moving on into adolescence and adulthood. And I believe strongly that this is a condition that really lends itself to a strong public health approach. I appreciate the guidance from FIGO around universal testing, and I think that we have all of the tools at hand to be able to really build a movement. And to the extent that I can support that as an individual and that we can organizationally at PSI, we applaud and look to work towards creating a healthier future for mothers and children around the world. Thank you.
Thank you so much, Heather, for describing an integrated model, combining prevention and management and integrating at different levels of care, and also highlighting the fact that diabetes in pregnancy is a public health issue. The program in Nicaragua had great outcomes for mothers and newborns, as did the one in Sri Lanka. You also mentioned patient empowerment, and Dr. Chandrika really brought the issue to life with the case of a patient. So I think there was a lot of interconnection and connected messages between the four presentations. I want to thank the four speakers. I want to thank the audience for staying with us a little longer. And I just want to mention that the next event will take place during the World Health Assembly in Geneva on May 24th at 2:30 p.m. at the Intercontinental Hotel. It will go live soon, of course, for those of you who cannot be there in Geneva. The event will go live soon afterwards, and will address ways through which advocacy helps translating evidence into practice. So thank you very much for attending, and see you next time.